Today's episode is packed with energy and inspiration. Thanks to our guest, Dr. Kaylee Dayton. Kali is a passionate critical care nurse practitioner, ICU consultant, and the voice behind the Walking Home from the ICU podcast. She's on a bold mission to reimagine ICU care, championing awake and walking ICUs and moving us away from outdated, sedation-heavy routines. In our chat, Kaylee opens up about her journey from traditional ICU settings to leading the charge for early mobility, better patient outcomes, and happier healthcare teams. Get ready for stories, real talk about financial and emotional impacts, and practical ideas on how smarter ICU practices can change lives, both for patients and for staff. If you've ever been curious about what's possible when we rethink the way we care for our sickest patients, or if you're looking for motivation to create change in your own corner of healthcare, you're in the right place. Let's jump in and welcome Dr. Kaylee Dayton to the conversation.
Kaylee, it's my pleasure to having you today. How's it going from your end? Sure, I want to have you. You have a very interesting and unique story, and I believe today we have a lot of clinical information here. I will try to make it as much as I can light, soft. We'll target anyone interested with the healthcare and give us more insight about what you are doing. But what you are doing, it's amazing and it's hard to absorb. Before we get in your business and your idea, who you are?
I'm Kaylee Dayton. I'm a nurse practitioner. I'm located in Washington State in the United States. I work with ICU teams mostly in the United States. I've helped teams internationally become awake and walking ICUs.
Most of the time, when we see a successful story out of the bedside, we see them more into a health tech, more into telemedicine, coaching. Those become familiar for everyone. But for you, it's totally different. You are now, do you practice?
I'm not at the bedside. I don't take care of patients. I primarily provide education, training, and consulting to ICU teams to help them optimize their own practices.
What you're doing, why when you step back, still you are, it's not stepping back exactly, but you're still working in the hospital. What is your philosophy? What is make you to make this shift?
I started my journey into critical care or working in an ICU in 2012. And in that ICU, almost every patient that needed a breathing tube and to be on a ventilator was awake, and they couldn't talk, but they would write on a clipboard, and they were able to mobilize, usually walk around the unit. I did that for a few years, and then I became a travel nurse, meaning I took different assignments at different hospitals around the United States for the next 2 years. And all the other ICUs I worked in, the standard or the normal thing to do there was to sedate patients into medically induced comas. And I didn't know the harm of that. I tried to explain to people what I was used to doing, and they didn't believe me. They were confused. They were concerned. They thought it would be really unsafe and scary to keep patients awake with a breathing tube and even moving. So I just went with what was normal to them. I sedated patients. I did what everyone else was doing. After a few years, I went back to my first ICU and was really happy to be back there and almost shocked to realize that we were keeping really sick patients awake and moving and that they did so much better. So it made me look into the research. And the more I realized the harm of putting patients in medically induced comas, that we were oftentimes doing that unnecessarily, and that it really changed patients' lives forever, the more I realized that the ICU community was not aware of that. If I had known all that information, I would not have done those things to patients. So it inspired me to start the podcast, Walking Home from the ICU. And as I did that, I came to realize that ICU teams need a lot of training and support and just education. They need lots of knowledge and encouragement to change these practices that they've been doing for decades.
So do you believe the physician and anesthesiologist, most probably they are not aware about the new research and study, or they are ignoring what is going in the research side, and they want to keep the same practice?
It depends on the clinician and the physician. It is a spectrum of knowledge. We've known that sedation has harm, but knowing how to do anything else is a big gap in the system. So there is a bundle that's been launched in the ICU community for the past 10, almost 15 years called the ABCDEF bundle, but that has been misinterpreted. So knowing how to apply that bundle, how to use those tools is variable throughout the community. So a lot of people may think that they're doing that bundle, that they're providing that care, but they don't really know what they're working towards. And again, how to actually master that bundle.
So here I will be very frank with this question. Is this any contribution from financial? So the hospital administrative, they prefer to have patient sedation because they will cost more, so they will be profitable more? Or this is something is not, I will make it clear in this way.
I think so. I think they have oftentimes staffed their units, assuming that all patients will be sedated. There are things in the structure of and staffing of the hospitals, just assuming that these patients will be comatose and unresponsive. But financially, it is in the best interest of hospitals to keep patients awake and mobile. They are actually losing millions and millions of dollars every year by keeping patients sedated and comatose. The thing is, they don't know that. They don't understand the alternative. We know that the ABCDEF bundle decreases healthcare costs by 30%. It can decrease readmissions to the hospital by 24 to 59%. And for certain patient populations in the United States, the hospitals are held liable for those readmissions. So they are very invested or interested in avoiding patients coming back to the hospital for certain patients. And yet they don't really know how to make that the least much of a risk as possible. So a lot of their decision making is rooted in their lack of knowledge.
And they consider these are sedated, and they have this rota for the department, for the ICU, for example. So that mean if they are awake, they need more, and in the youth they need more close monitoring. So in order to cover one issue, we make a lot of other sequence issue.
Yeah, I find that some hospitals are decreasing their rehab team, meaning their physical and occupational therapists. They decrease the staffing. They refuse to provide those therapists to be dedicated for each ICU. And they don't understand that by doing that, they're increasing costs. For example, one ICU, it was a cardiovascular ICU. They increased the staffing of physical and occupational therapists from 2 clinicians to 4. They decreased length of stay in the ICU by 3.6 days. I think in the hospital, it was almost 5 days decreased in length of stay. That is millions and millions of dollars just by increasing staffing by 2 more clinicians. So it's really spending thousands to save millions.
Yeah, and also this is will lead more for length of stay for the patient and exposes for more infectious disease and getting more bacterial and viruses in the hospitals, where they also will end up to increase their stay on the hospital with more complication and more medication.
And the hospitals are concerned about the complications. They just don't understand the roots of many of those complications. So the complications can include, like you mentioned, hospital-acquired infections, pressure injuries, falls, readmissions to the ICU,
Pressure
workplace
ulcer.
pressure ulcers or hoppies or whatever you call them, um, are concerned about workplace violence. But when patients become confused from these medications, they become more violent a lot of times. So again, we're just trying to pick the fruits off the tree without addressing the trunk and the roots of those problems.
Dig deep and understand what is the common misconcept from your protocol and having less sedation for the patient and keep them awake. what is the misconception from the healthcare provider when you try to promote the protocol of ABCD in order to have less sedation and keep them awake? What is, from your experience, you found the common misconception from this model?
Yeah, some of the myths that have been very prevalent in our ICU community for many years is that sedation is sleep, that it's providing comfort, it's preventing PTSD in our patients, it's safer for patients, it's easier for nurses. So those misconceptions really lead clinicians and especially nurses to aspire to have patients sedated. We have joked about sedation for many years. What we don't oftentimes get taught and get exposed to is the reality that sedation is sleep deprivation. It's depriving the brain of sleep. It cannot go into the REM cycle 3 and 4, which can cause serious and even long-term damage to the brain. And while patients are sedated and even weeks after, they can suffer delirium, which means that they're at high risk of having really, really scary hallucinations. But to them, they are vivid, graphic, alternative realities. So survivors have told me that they thought that they were being cannibalized by their deceased father and could feel every bite for days on repeat. And they thought they were kidnapped, their kids were kidnapped, they were being sexually assaulted. Just some of the worst alternative realities that are far worse than anything we could have done to them in the ICU is what they're actually experiencing under sedation. So then when you take sedation off, when you turn the pump off, and that sedation metabolizes out of the body, a lot of times these patients come out very agitated. They're trying to pull out their lines and tubes. They're trying to get out of the bed. It's very stressful for everyone involved, and that is dangerous. What we misunderstand from the ABCDEF bundle is that it really should lead us to keep patients as awake, communicative, autonomous, and mobile as possible, which ultimately should mean that we don't even start sedation unless there is a medical indication for it. But culturally, throughout the years, we've tried to transition into the bundle very gradually, meaning that we still start sedation on every single patient that is on the ventilator, but then we try to lighten sedation. We try to take quick breaks, holidays, vacations, interruptions every single day, which turns into a quick on and off switch where patients just come out and they start moving or thrashing and we turn it right back on. That's not letting them communicate. That's not informing them of what's going on. That's not helping them mobilize. So we do these steps and we document these things, yet we're not actually providing that care. We're not actually protecting patients from delirium. We're not actually protecting their muscles from becoming very damaged and weak. But we can chart it so you can follow all these steps of the bundle and still have patients sedated, laying there for days to weeks, and still accrue all of the damage that we're supposed to be combating with this bundle.
So walk us through the model of awake and walk ICU model, and then after that, if you can take us also through the ABCDEF bundles, what is should be and how it's be implemented, and we can see the the difference between the variances between how it's executed and how we need to improve it.
Yeah, a little history on the ICU that I come from. It was really inspired by a nurse back in the 1990s when they were giving Ativan, morphine, paralytic drips for weeks. They didn't know the harm of this. They thought patients were sleeping. We still sometimes think patients are sleeping, but back then they didn't have any research about it. My mentor, Polly Bailey, watched a survivor come out of the ICU, visited her at home, saw it even in her early 30s. It took her almost a year to be able to walk up the stairs. She saw how cognitively and psychologically damaged she was. So that led her to go and try something different in her ICU and to get patients awake on the ventilator. That led her to start a new ICU in the hospital where they would rehabilitate these patients, and eventually they started getting patients into their ICU shortly after intubation, directly from the emergency department. And that's when they started taking sedation off right away. They realized they didn't have to rehabilitate patients, that it was much easier now that the patients weren't confused, they weren't weak. They could start early on moving them and preserving their muscle mass and their cognition rather than trying to rehabilitate it later on. That's how they established the standardized protocol of having patients awake shortly after intubation. So if they got paralytics during intubation, then once the paralytics have worn off, an hour or two after, the sedation is off. And we don't turn it on unless there's a reason, like intracranial hypertension, status epilepticus, the inability to oxygenate with movement. If we don't have to give these high-risk medications, we don't give it. And so the bundle really was inspired by that ICU. So some of these people, Dr. Wes Ely, Dr. Gail Needham, these people that really made an impact on early mobility in the ICU community, they started those steps because they saw what my home ICU was doing in the early 2000s. So the tools of the bundle are trying to provide steps and tools to provide the kind of care that we provided in the wake and walking ICU. So if a patient comes from the emergency department and they're intubated, this was a medical surgical ICU. So sometimes they were intubated in the field, in the ED, then we would take sedation off unless there was a clear contraindication that necessitated having sedation running. As we would take sedation off, we would talk to the patient and say, you're in the ICU, here's what's going on, here's your family. We give them something to write with. And the cool thing about having patients awake right away is that they usually have the fine motor skills, the strength, and the cognition to write. When you wait 3-5 days later, patients can't write anymore. They can't text now, and they can't talk. So now they're even more frustrated and they can get more agitated. And then we just end up sedating them to try to just calm them down. We're just chemically restraining them. But in an awake and walking ICU, that's a huge priority is we are going to identify what the patient needs and treat their needs rather than mask it with sedation. And yes, there's some coughing and gagging with that too, but within 30 minutes to an hour, most patients are calm, cooperative. We can adjust things on the ventilator collaboratively with the patient to say, is that better? Is that more comfortable? And we get them up doing their highest level of mobility within 12 hours after intubation. So if they were able to walk, maybe they walked into the ED and they were short of breath and their oxygen was low, and now we've got them supported on ventilator, why not walk them? We use the ventilator to enable walking, to provide the support for work of
And you
breathing.
keep
And
posting those success story in your LinkedIn where they are walking and they are intubated and do a lot of fun and dancing. So it's like normal admission just with the tube.
exactly, we see the tube and the ventilator like a walker. We can increase support so that they can move, so that they can walk. But the mentality in most ICUs is that it's dangerous to move people if they are intubated. But the research shows that it's extremely safe and it can save their lives. People think that if the ventilator support is at a certain level, we can't move them, but I've walked people in maximum ventilator settings and it's really saved their lives. So that is so much easier to do within the first 24 hours after intubation. But in most ICUs, if they mobilize patients, it's like 6-8 days after intubation or once the tube is out. But it's really hard to get that tube out once patients become really weak and they're too weak to independently breathe. Now we've got tracheostomies and now we've got pressure injuries. And so all of this ends up being more efficient for the team. It is a little bit more work up front, but then you're saving days to weeks extra of work. And throughout the time on the ventilator, they're again communicating, being informed, helping make decisions, mobilizing, connecting with their family and the staff. And it really changes their chances of surviving and being able to go back to the quality of life they lived before. So that is the wake and walking approach in a very brief nutshell. There's a lot that goes into it, but the point is that we do not sedate them. We do not strap them to the bed. We do not stop them from moving unless we absolutely have to. So the ABCDEF bundle was the rest of the community's way of trying to say, okay, how are we going to replicate this process of care that they're doing in this ICU? Because it's safe, it's feasible, and it's so beneficial. So they tried to put together a bundle, a group of tools. It's like a toolbox. And so A is for assess and treat pain, right? It's really hard to keep someone awake and calm if they're in pain. None of us are going to stay calm if we're in pain. And that really should mean that we ask the patient, that we take off sedation and ask them directly, are you in pain? If someone is sedated, they're chemically restrained, they can't move their muscles. How do you know if they're in pain? So culturally, that A has been misinterpreted as just start a fentanyl drip on every single patient and call it good. Check the box. But we don't know if they're in pain. In an awake and walking ICU, A means for most patients, ask them. treat their pain, circle back and say, was that sufficient? That pain can tell us a lot of information about their condition. It can show us new signs of decompensation. So we need patients to be awake enough to self-report and identify their pain. B is for both spontaneous awakening and breathing trials, meaning that we wake them up as soon as we no longer have an indication for sedation. For most patients, that should be shortly after intubation. So we may not even have to start a drip. We just let them wake up after those medications we gave for intubation and then see what they need and see if they need sedation. The breathing trials are for when their ventilator settings are low, when it looks like their lungs are better or whatever condition led them to be on the ventilator. When we think that's getting better, we're going to switch the ventilator over to a mode that makes the patient take their own breaths to see if they're ready to get off the ventilator. Pretty reasonable, right? So we're going to wake them up. But because those two steps fall into the same letter, the cultural assumption has been that they go together all the time, meaning many ICUs do not do awakening trials. They don't even touch sedation. They don't turn it off until they think that it's time to get them off the ventilator, which for some patients, when they have pneumonia, ARDS, certain conditions, their lungs could need ventilator support for weeks. And we don't touch sedation, meaning that their brains are getting damaged, injured for a long time. They're sleep deprived for weeks because we've misunderstood when to do awakening trials. The only reason those two steps fall into that one letter is just so that it fits into a Q acronym to help us remember all the tools. But awakening trials should happen right away unless there's no other option. Breathing trials should happen when we're trying to get them off the ventilator. C is for choice of sedation and analgesia, choosing whether or not to sedate patients and then choosing the safest sedative. If we do have to sedate patients, we choose one that carries the lowest risk. D is for delirium. Assess, prevent, and treat delirium, meaning that we should have patients awake so we can do delirium assessments, and we should be implementing interventions that prevent delirium, like mobility, engaging with family, real sleep. But culturally, that is not so important in many ICUs, and we automatically start medications that cause delirium, and we take away their ability to sleep and their ability to engage with their family and to move. So we're really failing on the D in many ICUs. E is for early mobility, meaning as soon as possible. For many patients, that can be hours after intubation. Some patients, it might be days to weeks, but we should be assessing every single day. Can we move them? Is it worth the risk of not moving them? F is family engagement, meaning that we have patients awake, communicative, and able to really engage with their families, not just having families there a few hours a day. There shouldn't be family visitation restrictions. We should allow at least one person to be there with their loved one at night. So that's the bundle. Those tools together help us. Yeah.
I see that to implement ABCDEF, there's a lot of restriction with the current setup. So one of them I can see, if we consider they are happy and they want to implement it as is in the right way, having ventilator mobility, maybe this is one of the infrastructure issue, and have the right space and design with the ICU is need to be considered from beginning. This is one of the issue. Family, as you mentioned, the visiting time is limited, and this is not the concept they are welcoming anyone to come. There is a specific day, time, and not everyone are welcoming, not every patient are welcoming to come and visit their patient. So even though if we consider all as a clinician team, we support this idea, and we are not, but if we still, there's a lot of consideration to be tackled. So from your experience, and for sure you came across those challenges a lot. First of all, before we get in those challenges, I want to understand, when the patient admitted for the ICU, there's a window between the team to discuss, shall we put the patient in, assuming the patient is not in sedation, shall we implement it ABC DF bundle and keep them awake immediately after the sedation, or keep them sedated? This window and discussion, if we can walk us through it, a real scenario between whom the discussion will be and who is the final call. I know this is maybe silly question for you, but for other, maybe this is, they cannot understand how the situation is going inside the
That discussion really depends on the team. meaning the team's dynamics, expertise, experience, where they're at with the bundle. So in many teams right now, there is no discussion. It's just a conveyor belt. It's an automatic response. As soon as you're getting the ventilator set up, you're already hanging the propofol because you're already going to start that after intubation. There's no discussion. There's no critical thinking. Now, in an awake and walking ICU, especially the one that I came from, they've done this for almost 30 years. So I honestly never even considered sedating patients immediately after intubation unless there was an exception. I never even critically thought through it. It was my routine. We all have routines, right? Things that we just do that we don't know why we're doing them. One of those things was to start talking to patients after intubation. It was an expectation. So I interviewed one of my colleagues in the Wake and Walking ICU for my podcast, and he said, went into this ICU shortly after fellowship. He was very used to the conveyor belt of sedation automatically. So after he intubated a patient, he turned to the nurse and said, "What do you want for sedation?" Because that's what he was used to doing in all the other ICUs. And that nurse in that awake and walking ICU said, "Never say that again. We don't do that here." And that was a discussion. Now, I'm thinking of another scenario in which it was a little bit of a gray zone. So we had a patient that had Down syndrome and autism. He was a 21-year-old. He had pretty sick lungs. He was going to need fairly high ventilator settings. And so after intubation, there was a discussion because many adults can understand what's going on. He was not going to. If he pulled out his tube, he would be in big trouble because of how much support he needed. But then we also had to discuss with such a fragile brain, he's at a 3 to 4-year-old, a cognitive level. If he had a brain injury from that sedation, that would be devastating for him and his family. If he lost the ability to toilet himself, feed himself, do these things, remember his parents, it would be awful. If he developed delirium, he'd be really hard for us to manage because he would be so scared and confused. So we had to weigh that out. So we did do that as a team. We said, we don't usually sedate, but what if he needs some sedation? So they put him on a little bit of Precedex, but they took it off shortly after, a very light, safe sedative. But within hours, he was walking and he never needed any sedation. So that kind of discussion can happen when you have more tenuous things. I mean, if a patient already in the ICU I worked in, there were a lot of polysubstance abusers. There's a psych unit, a detox unit in the hospital. We had a drug park around the corner. So a lot of that kind of patient population. So if they came in and they were on a methamphetamine high already, we already knew that we would need some sedation. But the goal would be to keep them as awake as possible. We would just use sedation to keep them in a safe zone. So those conversations happen when you have a team that understands why sedation is so dangerous, and they have a skill set to keep patients as awake and mobile as possible. Many ICUs don't have that knowledge. They don't have that skill set, and they have the culture and the conveyor belt of just automatically starting sedation. So it depends on where the team is at.
So what make the hospital, they have that culture and advocate to have the patient awake, and other they don't consider this as an option? For example, why your hospital, since long time, they consider this?
Because of that nurse, Polly Bailey, back in the 90s. Because she saw the damage and she started to experiment and found how much better patients did. She and her team at the time were the first to publish a study showing that it was safe and feasible. And that was in 2007 that study was published from a data collection in 2004. So when I came on in 2012, no one really made a big deal out of it, other than the nurse manager asked, "Would you be willing to walk intubated patients?" Because if I said no, I wasn't going to get hired. I was not going to be a fit. They already had that so established, but no one made a big deal saying, "This is so cool. This is so exceptional. No one else does this." No one told me because many of those people didn't even know what
the culture embedded there and the protocol is implemented. So it's easy to absorb and started to get it that. Yes. If other hospital, now, what I understand from you, your mentor, she started that fight from down to up, and they adapted and they implemented. Other hospital right now, they consider the other hospital like your previous employer as a role model, and they try to see how they implement it and take the lesson learned from them and try to implement it? Or this kind of collaboration is still weak between the hospitals?
Still very weak. Most people don't really know about that ICU. They don't understand what the bundle is for. They especially don't understand the roots of the bundle. So they think that they're practicing it because we just do what we've been taught. We're all a product of our experiences. So they're like, "Oh yeah, the ABCDEF bundle, do daily awakening trials, just turn it on and off." I mean, that's what I learned as a travel nurse in 2016. A charge nurse in one of the facilities I worked at said, "Oh, here we do this annoying thing. At 5 a.m, you just turn sedation down enough to see them start to move around. And then once you see how uncomfortable they are, you just turn sedation back on and just chart failed awakening trial. That's how you know they haven't had a stroke and that they can't tolerate the ventilator. So that's how I was taught. Nothing about delirium, nothing about get them awake. And they were so hard to manage. I was like, well, I guess this is what we do here. But why were they hard to manage? Why were they thrashing? Why were they confused? Why were they trying to self-extubate? I didn't ask those questions. I was confused because I was like, can't tolerate the ventilator. I've seen hundreds of people tolerate the ventilator in my home ICU, but I just kind of shut up and did what I was told, unfortunately. But that's how a lot of us are, right? We just do what we're told. So this has been stuff that's been passed on generation to generation. So many hospitals, I think, have the box checked. They think, okay, bundle check, because they require charting on those elements. But you can chart all of those things and still have patients deeply sedated. So hospitals have a really hard time once they do realize what's actually going on. It's really hard to convince clinicians to change. It's really hard to lead something you've never done before. Like my home ICU, they have that expertise, but most people have never seen it done that way. They've never really seen patients awake and walking on a ventilator. So then how do they get their whole team to convert into this whole new way of practicing? Like,
But you
where's
are
the guide?
doing a great job. Since we connect years, I see you have your podcast, and you've been Best Nursing Innovated awarded, and you bring a real success story, interview the patient and their companion. You do an amazing job, but still the challenge is there. So you try to make the change not only in your home hospital, also worldwide, national wide. And what I'm hearing from you is still the challenge there, and the clinicians, they are not aware. So what can be changed to make those hospitals to adopt the real way to implement the ABCDEF bundles and make them awake? For me, as an outside, I don't work with you. Never. I see you working the right way to promote this in each hospital and culture, and you try also educate the patient and their family and companion. So from your side, done, boss, but nothing changed. So
Hospitals, like, this won't be a standardized approach until hospitals are held accountable for it. Right now, they're getting reimbursed for some things like tracheostomies that should be unnecessary and preventable. They might get reimbursed for it. They don't have to, they're not being audited for ventilator associated pneumonias. They're held accountable for things like pressure injuries, eclampsies, certain complications. So I really try to hone in on those. But until reimbursement agencies, at least here in the United States, unless they say, listen, unless you are providing this kind of care, we're not going to pay for those complications. So if that was a preventable tracheostomy, we're not going to pay for it. If someone walked into the hospital and then can't walk leaving, if that's not a very justifiable, unavoidable situation, we're not going to pay for that rehabilitation. You get to pay for it. Once that
those
happens,
CME in US, they call them, right?
CMS.
Yeah. So if the hospital, they are not reimbursed for any procedure, then they will start to implement those procedure overall.
Well, if they're
Anything
like,
will
wow, this patient needs to go to a long-term acute care hospital because they can't get off the ventilator because we didn't mobilize them, because their diaphragm, their respiratory muscles atrophied, or they're so confused. Now we get to pay for the tens of thousands or hundreds of thousands of dollars for that admission, because our care, our failure to protect them from those complications led to this scenario. But right now, they don't have to pay for it.
What is stopping them from implementing this from CME to be audited and see all those complications?
I think they're really just not aware of how expensive this is, how preventable it is. Because again, almost universal mentality is that in the ICU, everyone is going to be sedated. That's just the way it's been, and that's just the way it is. So I even look at a lot of medical device companies, alien lifts. People try to create all these tools to continue that practice. There's just very little awareness that the standard should be awake and mobile. So people might see my stuff online and they're like, well, that was a fluke. That was a rare occasion. That must have been just that specific patient. People ask me questions all the time online, such as, why isn't that patient extubated? If they're awake and walking, they shouldn't be on the ventilator. To which I had to explain, well, this patient was on a PEEP of 18 and 100%. If we pulled the tube out, they would die. So they just think that there's just such a mentality of, yes, mobility is good, but let's do it. But we do it on the back end. Once they're really weak, once they have a tracheostomy, now we'll rehabilitate them. So CMS, to me, these organizations don't really think, they don't understand that this is so preventable. They don't realize that they're paying for bad care.
Have you ever tried to connect with them and make a connection through them directly or through your network?
It's such a bureaucracy. It's really hard to get to anyone that actually influences or controls anything. That kind of endeavor is a full-time job. There are activists that really focus on those kind of things. I need to. I'd be happy to be involved in it if anyone wants to invite me. I've just been really focused on staying alive myself, taking care of my family, and creating a program in which when hospitals are ready, I can come in with a team and help them make the changes.
So if you can send them messages through this podcast, assuming they are watching us, hopefully, what you want to tell them anything you want.
We've covered some incredible ground today, but our conversation is far from over. In our next episode, we'll dive deeper and explore even more fascinating insights. Stay tuned for part 2 of our conversation on uncharted narratives. If this episode sparked something in you, here's how you can keep our mission alive. Subscribe to Uncharted Narratives Certiat. Leave us a 5-star review. It helps more amazing people discover our stories. Share an episode that moved you with a colleague or friend. Connect with me on LinkedIn and join our healthcare innovation community. Together, we're not just telling stories. Until next time, stay curious, stay passionate, and keep pushing the boundaries of what's possible in healthcare. See you in the next episode of Uncharted Narratives Certiat.